So hello and welcome everyone to our town hall, Kids and the COVID-19 Vaccine. So I'm Lisa Stromquist and I'm the Associate Director, Strategy and Engagement at Children's Healthcare Canada. And I'm thrilled that you've taken some time to join us today for this important discussion. But before we get going, we have just a little bit of housekeeping. Our session is being recorded. And we're going to try to keep everybody's lines muted to eliminate any background noise. And I will be calling on some specific individuals to unmute themselves and ask their questions. We have received many questions, more questions than we likely have time for today, but we've tried to group them into themes and believe that we can cover most of the concerns. And we will be sharing some other resources after the session. So it's really my pleasure now to introduce our guests today. Dr. Megan Bedell, Director General of the COVID-19 Regulatory Response Team in the Health Canada Products and Food Branch at Health Canada. Dr. Bedell joined Health Canada as a drug safety reviewer in 2005 after a PhD in postdoctoral studies in molecular biology and the genetics of rare diseases. Since then, she has held positions in pre- and post-market drug review, cannabis policy, and surveillance of tobacco and problematic drug use. And we're also welcoming Dr. Jim Kellner, who is a pediatrician and subspecialist in pediatric infectious diseases. So between 2008 to 2018, Dr. Kellner was the head of the Department of Pediatrics at the University of Calgary and the Calgary zone of Alberta Health Services. And his research interests are in the field of vaccine preventable infections, and he works with colleagues from clinical medicine, public health, and basic sciences locally, across Canada, and internationally. And Dr. Kellner is also a member of the Federal COVID-19 Immunity Task Force Leadership Group and co-chair of the task force's Field Studies Working Party. So he's leading the multi-faceted Alberta Childhood COVID-19 Cohort study, and in his spare time is an investigator with the Canadian Immunization Research Network and is co-PI for Alberta on the Canadian National Vaccine Safety Network COVID-19 vaccine project. So welcome to you both, and thank you for taking our questions today. Actually, I'm just going to let the audience know, like I said, we have a lot of questions to get through. We will, if there's time at the end, we'll allow for some follow-up questions if there's time. So welcome to both of you, and thank you for taking all of these questions today. And before we get into into the discussion, maybe you can each tell us a bit about what you do in your role in the pandemic response. Megan?
Sure, I can start. So thanks for having us here. This is a really exciting thing to be involved in. So when the pandemic started, I was in a slightly different role where I was responsible for the review and authorization of clinical trials for COVID vaccines and for any sort of biologic treatments. Kind of last fall, I moved into this coordination role that I'm currently in. So the Health Products and Food Branch of Health Canada is the part that reviews and authorizes drugs and monitors the safety of drugs. And my team kind of works with all of the different scientific areas to coordinate communications, what's on our website, and information for the public, and kind of all of the things that go along with the approval of vaccines so that the scientists can actually focus on doing the review as quickly and thoroughly as possible. So we touch on a lot of different things.
Yeah, and thanks for the kind introduction. Very happy to be here and happy to be with so many folks today and have a chance to talk about some of these issues related to COVID vaccines in children. I have sort of, made my way into a variety of different COVID-related roles locally here in the province of Alberta, and then some nationally as well, and especially as vaccines have gotten going. Oh, there's some extra noise there, but especially as vaccines have gotten going, have been particularly involved in some of the work around vaccine planning and delivery in our part of the world. And the COVID-19 Immunity Task Force, which was established by the federal government with the co-chairs, Dr. David Naylor and Dr. Kate Hankins, was really focused on issues around sort of the immune response and seroprevalence, antibody response to COVID-19 to begin with. But there's been a big pivot towards evaluating vaccines, because quite clearly vaccines are the #1 tool that we have as a planet to help address the COVID-19 pandemic. And that group has really been doing a lot of work related to supporting efforts to understand and help with the rollout of vaccines.
Great, thanks so much. Diana Delgado, can I ask you to unmute and ask your question?
Hello, good day, folks. This is my question. We have been told children are not super spreaders. We have been told that if an overall healthy child were to get COVID, it would likely be cold-like symptoms. Why give a child an experimental drug? Why not focus all efforts, vaccine inventory, and taxpayer dollars on adults who are more at risk? We should get second doses in arms, wait for the data, continue research, and vaccinate children when the vaccine is fully approved and gone through the rigorous process of all other vaccines that are mandatory for children.
Megan, do you want to speak first about regulation?
Sure, sure.
Okay, now go after.
This is where we find out that we actually didn't decide who was doing which question.
No.
So let me talk first about review processes and the current status of the vaccines. And maybe I'd also like to start off with sharing that I am the mother of a 13-year-old girl and a 15-year-old boy. And we signed them up for their vaccines almost as soon as they were eligible, and they were vaccinated on Friday. So I'm a very strong believer in vaccinating children as well as adults. So Health Canada has used a slightly different legal tool to bring these products to market. So at the very start of the pandemic, all of the international regulators worked together. We developed consistent requirements for what we would like to see in a vaccine with respect to the types of studies, the amount of data that we would want to see. And then each regulator in the World Health Organization has looked at it kind of differently. What we realized really quickly is that there were certain elements of the food and drug regulations as they are that weren't as flexible as we needed for the situation. So there was this thing called an interim order put into place, which really allowed us to use a more flexible process to review these products. But all of the review process was actually quite detailed. So we still required animal data. We still required all of the phases of clinical trials. We still required very large trials and ongoing follow-up. So we've made an authorization decision, which is slightly different, but I wouldn't characterize these as experimental at all. They've been very well characterized before they've been introduced to the general public. And now we're in a space where for Pfizer alone, there have been over 160 million doses given worldwide. So they're very well characterized there. With respect to children, Dr. Kellner can talk more about the risks, but I would say that risks are still non-zero. So there have been over 1,000 children who've been hospitalized due to COVID. So that's a consideration as well. And I think it's also really important to think that children can still, they may not have serious disease, but they can still transmit it to others. So I think now where we have vaccines which reduce transmission and we're really seeing the impact of those, I think also vaccinating the children is important. I would also say too that this age group is less than 2 million people. We're now getting more than 2 million doses of vaccine a week nationally. So I think we can do both. I can think we can start to vaccinate the children, and we can get those second doses, which are critically important, into people as well.
Thank you so much. Can I just add one more question to that? Does the vaccine does it stop the spread?
So maybe I could pick up and comment on that specifically, and a couple of the other points that you made with your questions there, Diana. It was a broad question with really important points. I think to the point of stopping spread, for sure, and we're talking here now when we're talking about vaccines for children, we're talking about the mRNA vaccines, the Pfizer vaccine, and now heard from Dr. Bettel that just this morning, the Moderna vaccine has been submitted to Health Canada for approval for 12 to 17-year-olds. So could soon be another vaccine to be used, but it's the 2 mRNA vaccines we're looking at. And there's really good increasing real world evidence showing that once you've been especially fully vaccinated, that vaccine does reduce spread. It does stop transmission. There's all kinds of numbers around the vaccines, and it's easy to get sort of mixed up in the numbers. And the main number that gets reported is the number around, okay, how well does it prevent any infection with any symptoms, even milder cases? And those are the numbers where you hear things around 70, 80, 90%. The other numbers we're always worried about is what about severe disease? That number is always higher. So if the vaccines are 80 or 90% effective at preventing any infection, they're going to be even higher at preventing severe disease. To prevent transmission tends to be a little lower, but the interesting thing with the data coming from adults, especially in the UK, healthcare workers and the US data, shows that the reduction of transmission after you've had 2 doses is almost equivalent to the reduction in any infection. So that's a really important thing, is that it does prevent transmission. And that comes back to one of the important reasons to immunize children. In addition to protecting children themselves from getting COVID-19 infections, the hope is that they'll contribute to the overall aim towards getting as many people immunized as possible and helping dramatically reduce the amount of virus that's out there. I think the thing about super spreaders that you asked, it's, super spreaders are a small percentage of the population. The issue comes back to, are children involved in transmission? And the short answer is absolutely yes, children are involved in transmission. And part of our challenge around transmission is highly variable approaches to how often children are tested to look for COVID-19, whether or not they're sick, or whether they're contacts of people who have been sick. And in Canada, several provinces, especially Quebec, Ontario, and Alberta, have done a lot of testing. And in my own province of Alberta, where we've done a lot of testing from the beginning, including children, if you look at the overall number of cases of COVID-19 that have been diagnosed in Alberta, a quarter of them are in children and adolescents under the age of 20. And it's equivalent throughout that whole age span. And that's a quarter of our population. 24% of the population is under the age of 19. So on a person-by-person basis, if you look for it, we found just as much COVID at all ages, including under children and adolescents, as in older age groups. And as Dr. Bettel said, for sure, and everybody's grateful that the severe outcomes of COVID are far lower in children, but they're not zero, and that's an important thing. There have been, lots of hospitalizations, a very small number, fortunately, of deaths in Canada in children and adolescents, but there have been a few. But not trying to sell it as something where it's equivalent to adult. It's far less deadly for sure, but other aspects of the impact of COVID-19 are still coming to be understood. Other manifestations, this MIS-C, multi-system inflammatory condition related to COVID, and and then the question of long COVID, and then just the disruption that COVID has brought to children and families as well as all of society. Through school infections and school outbreaks, and it remains, and we'll never get through too many questions if we go too long here, but I just want to, such an important part of it, when you talk about the schools, and there's been lots of controversy about whether outbreaks can occur in schools and whether schools contribute to COVID or not. And there's information on both sides of that, and it has a lot to do with how it's been all tested and everything. But when the one thing you can say for sure, when there's a lot of COVID in the community, there's a lot of COVID in the schools. And schools have been very disrupted in different ways across Canada. And one of the hopes for vaccination is that it's going to help eliminate that disruption going forth by next year. So it's a lot of information about all your points, but thanks for asking such a broad question.
Thank you so much.
Thanks. I think that sets a really good context to start the discussion. So, Paul, I'm going to unmute you. Ask you to unmute and ask your question.
Hi there. Thank you to everyone for organizing this event and for providing the information in the conversation. The question that I had was, I was hoping you could talk a bit about the potential for a variant to pierce the vaccination protection that we currently have. As it's been in the news lately, the increase in the so-called Delta variant. Anyways, I was wondering if you could talk a bit about whether you think there's going to be a resurgent variant that's going to spread and kind of put us back into the same situation that we were in at the beginning. Thank you.
Do you want me to speak first? Okay.
Sure.
I think so. It's a really important question, Paul. Thank you very much. Yeah, variants, I'm not sure if they're more or less confusing since the renaming has happened, but now I've gone to Greek letters. And so the Delta variant that you speak of is this variant that was formerly known as the B1617.2 and relatively newly identified variant, first identified in India, and which has been appearing in tiny amounts in Canada so far. By far the biggest variant that we've seen in Canada has been the now the Alpha variant, or the B117, which was the variant that became the predominant form of infection in the UK and has become the predominant form of infection in the third wave across Canada. The short answer to your question, well, there's two short answers to your question. One is we don't know for sure about the existing variants, but we do know more and more about before we got to the Delta variant, about the other main variants, the B117, the 1351 or beta, the P1 or gamma. And the main thing we know there is that, yes, you may in a test tube see a reduced overall amount of immune reaction to that variant if the vaccine was given for the vaccines that we're using now is given. However, you still get protection, because when you think about the amount of protection that you need, if you say that you need protection at this level in antibodies and your cellular immune response, and if the vaccine gives you protection up here, then it far exceeds what you need. If your protection that you need against a variant is up here, and you still get here, you're still going to be protected. The key message that we're seeing so far is that for all the variants, you need both doses of vaccines. And this is even, there's a little bit of data coming forward now on the Delta variant, the B1617.2, to say the same thing, that the level of protection from some data from the UK shows that overall a reduced level of protection, but dramatically better when you've had both doses of vaccines. And so it's not just for the so-called ancestral strains, but particularly for the variants. The key message is get both doses of vaccines. And this is acknowledging that except for the Johnson & Johnson vaccine, which we haven't approved but not started using in Canada, they're all 2-dose vaccines at this time. And so in the medium term, will we see the development of variants that will not be protected by the existing vaccines? This is then where we get into sort of comparing SARS-CoV-2 and COVID-19 to influenza, where that is every year fact of life that you get continued evolution of the influenza virus, and we need to give different strains of different forms of vaccine, slightly different forms of vaccine on an annual basis to protect against the changes that occur. Remains to be seen how that's exactly going to play out with COVID-19. There are studies ongoing right now with booster doses of some of the vaccines, especially the mRNA vaccines that include a benefit against the variants. And so we'll see how well those work. And the question is, how necessary will boosters be, and how necessary to both extend immunity and protect against variants. I'll leave it at that for now.
Sure. The other thing I would add there too is that the mRNA vaccines in particular are actually relatively quick to modify. So if we ever got to a point where the current vaccines are not as effective as we need them to be, they can be changed pretty quickly. And based on what we know about the vaccines and the immune response and the way we normally deal with changes to strains for flu vaccines, we have a way of allowing those changes without requiring the vaccines to go back to massive studies of tens of thousands of people, so that we can adapt those fairly quickly to new strains as need be.
Great, thank you both. Megan, you spoke a bit about the approval process and how some of the regulatory pieces have changed, through this crisis. Can you speak a bit about maybe a surveillance process that would help ensure, like, what is the follow-up of potential long-term effects of these vaccines on children? Will there be follow-up to surveillance?
Yeah, so absolutely. So all of the clinical trials which have been used to assess these vaccines, they are ongoing because we're requiring at least 2 years of follow-up. So the initial parts of the trials looking at efficacy have been done, and then there's safety follow-up for the next 2 years. So both for the adults and for the children in trials. So that's just the clinical trials piece. We require manufacturers to continue to evaluate their vaccines. So we're requiring monthly safety reports where they have to provide us with all of the safety data from across the world to tell us if anything's changing with the safety profile of their vaccines. And then within Canada, we have ongoing surveillance, both that the manufacturers of the vaccines are required to report any safety issues and their analysis of that to Health Canada, again, constantly, as well as these monthly safety reports. And then on the public health side, if there are any adverse reactions, those are reported through local public health units. And all that data comes together. We have teams looking at all of these reports to assess them, to see if anything's changing about the safety profile of the products. And we're also working constantly with our international partners. So we meet weekly with all of the other big regulators where they've deployed the same vaccines, so that we can talk about the safety profile, talk about whether anything's changing or whether we've seen something that needs more investigation. So there's a really high attention paid to the ongoing safety of these products. And as long as they're on the market and in Canada, they are being watched over, and we're looking at the safety profile.
Great, thank you.
I might just add a bit on that, if that's okay.
Mm-hmm.
Just about the thing of it's just to sort of provide a little bit more on what's going on with the effort to try to understand in Canada about safety issues. And 2 points I want to make. One is about so-called long-term safety effects, and I'll come back to that in a second. But the safety surveillance that occurs, it's a routine thing for vaccines to be looked at for safety, even ones that are long established. And all the provinces and territories have some kind of system of what we'll call passive reporting, where health professionals are expected to report if they see somebody who comes to a health facility with an event that occurs correlated in time with having had any kind of vaccine. And this is so-called APHI system, adverse events following immunization. It's a great system. It is passive, so it counts on people thinking of it to report it. But I will say, as a medical practitioner, that the level of sort of awareness right now of the concerns about vaccines is so high that I think we're at a place where it's improbable that we're going to see serious outcomes related to vaccines slip through the cracks. Of course, anything can happen, and I'm not saying our system is perfect or fail-proof, but I think that there's such a high level of awareness right now of the importance of saying if somebody comes in with anything, is it possibly related to a vaccine or not? There's that. And then the other thing is in terms of active surveillance, where we're asking people. This, you mentioned at the beginning, a project that I've been involved with, the Canvas COVID project, which is an extension of a project that's been looking at flu vaccine safety for over a decade. But in multiple provinces and territories across Canada, over 900,000 people so far have signed up to receive a survey. That they would get a survey after their first vaccine, about a week after their second vaccine, and then 6 months after the third vaccine. We don't have any of those back yet. But we've already had reports from almost 500,000 Canadians on the first dose, and not that many on the second dose yet, but asking about things that have happened to them in the time after they've had the vaccine. So there's a real big effort to contribute to that understanding of the impact of vaccines in Canada. And I do just want to, the thing of long-term effects of vaccines. One thing, and this will probably be received as somewhat controversial, but one of the things that is out there as an aphorism or a truism is that severe effects that can happen after any vaccine, and any responsible vaccine delivery program in Canada and in any other country has to have a safety monitoring component to it. You can't responsibly deliver vaccines to the population without having an open, honest, transparent, truthful safety monitoring program, and acknowledge that sometimes severe adverse events can occur. The thing with vaccines is that if you're going to get a severe adverse effect, there hasn't ever been severe adverse effects that haven't been present within a short time after the vaccines have been delivered, at the outside, 6 weeks. And now, if you get a severe adverse effect from a vaccine, the impact can linger. There's no doubt about that. If you've got something where there's a severe effect, it could linger potentially for a lifetime. Fortunately, such effects are very, very rare. But when you're talking about, and I know that, when reviewing questions people have submitted, there's a number of questions about long-term effects, and we can come back to this. But when we think about the effects of vaccines, we need to monitor them for the long term. But we don't anticipate unearthing effects 10 years from now that were related to the vaccines. People will be keeping an eye because it could change. But with vaccines that have been used up to now, in the world, we anticipate that the severe outcomes and any severe adverse events are going to be present soon after the vaccines are provided, within a single-digit number of weeks.
Okay, great. I think that leads well into the next question from Alda. Are you there, Alda? All right, well, she was wondering what adverse responses have occurred in children for the various vaccines. So Pfizer versus Moderna versus AstraZeneca, which ones are used in kids and what have been the reported side or adverse effects?
Okay, I can start with that. So right now, the only vaccine that's authorized for kids is Pfizer, and that's authorized for 12 and up. As Dr. Kellner just said, we've just received the data for Moderna's study as well, also for 12 years in age and up. And we're not anticipating pediatric data for AstraZeneca at this time. That's just authorized for adults. So what's been seen with children has been almost identical to what was seen with adults. So what you're likely to get is a sore arm, possibly a fever, possibly a day or so of muscle aches or feeling like you have chills or the flu or something like that. But that's about it. In the clinical trials for Pfizer, the frequency of these events was slightly higher than in the adults. So maybe 20 to 30% had chills, for example, but it's very similar safety profile, and it's exactly what you would expect and is seen for any other vaccine.
Great. Thanks so much. I have another question here. If a child had an allergic reaction to the H1N1 vaccine, should a parent be concerned to the point of opting out about their child and the COVID vaccine?
So I would say that there was a lot of attention when we first authorized Pfizer because there were reports of anaphylaxis at that time. Every vaccine has a risk of anaphylaxis, but it depends on a very rare risk, I should say, but it depends on the ingredients. So in some of the information I'll provide later that can be circulated, the ingredients for all of the vaccines are listed on the Health Canada website. The mRNA vaccine ingredients are very different from other vaccines. So it's the messenger RNA, it's a bit of fat, it's a bit of which protects it, it's a bit of salt, but it's quite different from other vaccines which are used. But there are no eggs, there are no common food allergens, there's nothing to suggest that if you had a reaction to one type of product, you would necessarily to this vaccine. There's also some really good information out on allergies from Food Allergy Canada, who've had a lot of questions about allergies of all kinds. So I would encourage people to look at that as a resource. But ultimately, there's no reason to expect that an allergy to one type of vaccine would be the same for the COVID vaccines.
Great, thanks so much.
Can I just add about H1N1?
Go ahead.
So sorry, just that, so the H1N1 pandemic back in 2009-10 especially led to the development of H1N1 vaccines. And, when children or adults get vaccinated now with the flu vaccine, it's a multi-component flu vaccine. Either 3 or 4 strains of influenza are in it, and H1N1 remains one of the components of the existing vaccines that we're using now. So they actually got, it's not just from back in the day when H1N1 was first tested at the time of the H1N1 pandemic, but going forward, it remains one of the predominant strains that's out there. And so people are getting H1N1 vaccines if they're getting vaccinated on a regular basis. So in addition to the important points Dr. Bettel made about all the components, that actual virus is one that we're still routinely immunizing against.
Great, that's helpful. I have a question here from Katie Eager. Are you able to ask your question, Katie?
Absolutely. I was wondering if there was any data surrounding children with medical complexities in the COVID vaccine.
I'll start with this, and Dr. Bettel will tell us about, the more details about the studies that were submitted for approval. But so far, there is very little data on children with medical complexities, and most of what we know about that is by extrapolating from what we know about medical complexity in adults and young adults as well as adults with complexity at later ages. And so much of what we're anticipating, you would extrapolate from one large group that you see in young adults, but especially in children as well as those who have complex neurodevelopmental disorders. And children who may have related to that, an underlying increased risk, especially of respiratory infections. And so this includes children with genetic anomalies such as trisomy 21 or Down syndrome, children who have forms of cerebral palsy where they have increased risk of respiratory infections, That's a group for which there was a lot of advocacy before the vaccine was approved to say, we know that in young adults who have those kind of disorders and older adults who have those kind of disorders that they're a particular risk. And so there was a lot of advocacy across the country to try to ensure that that was a group that was included as a high-risk group at any age. And that certainly goes down to children as well. We know that when it comes to COVID-19 disease in children, if you look at the kind of children who end up with severe disease, one of the groups you look at is very young children. So premature children who were very premature and had premature development of their lungs. Those are kids who are more likely to have ended up in an intensive care unit related to COVID afterwards. So that's a very young group, which we're not vaccinating yet. But then other underlying serious chronic disease related to serious lung disease, heart disease, cancers, immune disorders, autoimmune disorders, disorders where people are on medications that will alter their immune system, whether they're autoimmune or immune deficiency disorders, or where they have cancers or transplants and have to be on. So it's a fairly long list of people who either because of the condition that they have or the treatment that they're receiving, they're at increased general risk of infection, and from our adult data, particular increased risk of infection. And so you can identify a smaller proportion of children that is at particular risk based on their underlying conditions they may have. And this works out, I know we looked at this in Alberta, to be about somewhere around 15% of the population of children. And that's a rough estimate, so please don't sort of hold that, but somewhere in that ballpark of children who have a particular risk.
Great, thank you. We've had a couple of questions about children going through puberty or prepubescent children. Are there any long-term or potential long-term effects of the vaccine on this age group, or does it interrupt menstrual cycles?
I could start with this. So two questions there. One is about puberty and the other is about fertility and pregnancy. And so, in the same way that, and Dr. Butta could speak to this better than I, but is in the same way that children weren't initially studied in the large vaccines trials that were conducted, neither were pregnant women. But nonetheless, information on both pregnancy, pre-pregnancy, and the outcome of pregnancy has been gathering, because both in the clinical trials where life happens, and women who participated in the clinical trials got pregnant just before or just after, didn't know they were pregnant when they got vaccine. And so there's a small number of women who have been followed through the clinical trials and we're finding out about, and then as well, especially from surveillance done early on in the UK and the US, and now increasingly in Canada, some really great data looking at COVID-19 and pregnancy. Two things to say there. One is, if you're pregnant and you get COVID-19, the outcomes can be worse than if you're not pregnant and get COVID-19. If you compare pregnant women with and without COVID, and if you compare pregnant women with COVID to non-pregnant women with COVID, the more severe outcomes, and in some countries of the world, higher death rates. In Canada, more severe outcomes, more hospitalization, more ICU. And so getting COVID as a pregnant woman, it's similar to influenza that way, especially later in pregnancy. You don't want to get influenza. We think of it as a benign disease very often in young, healthy adults, but young, healthy women can get severe influenza, and the same thing can happen with COVID. So there's that. And then as well, there's then the impact of the vaccine on fertility. There's been this thing of, is there a cross-reactivity between the antibodies we make against the spike protein, against a component of the surface of the uterus, syncytin protein? And they're just not similar enough. They have some very slight amount of overlap in terms of their protein structure, but there's increasing data coming forward on the lack of impact on fertility, on being able to become pregnant, on staying pregnant, and on outcomes of pregnancy in terms of pregnancy loss, miscarriage, or late pregnancy loss, on prematurity, and on impact on the fetus and newborn. And there's some really good sort of collation of this data as it comes forward that is showing the lack of negative impact of vaccine, the rationale for protection of vaccine in pregnancy. And so coming back then, is it going to, in a teenager who's going through puberty, will it affect fertility in the long term? No evidence from of anything to be concerned about for that. We don't know about very, very long term for years in that, but come back to the point, we don't expect vaccines to have effects that don't declare themselves for years afterwards. We give other vaccines in adolescence around the time of puberty. The vaccine schedule is different from province to province, but we give a lot of vaccines, either booster doses or the initial doses of vaccines, somewhere between 10 and 15 years of age, depending what province or territory you live in. You get booster doses of your early childhood vaccines, diphtheria, pertussis, tetanus. You may get hepatitis B vaccine at that age, although it's been given more and more to infants. HPV vaccine, human papillomavirus, is given in that age group. And the experience of all those vaccines is, and it's come up as a question: is there an impact of those vaccines on fertility? And hasn't been shown to be the case. And there's no reason to expect it's going to be the case with COVID vaccines.
Great. Do you have anything to add, Dr. Biddle?
No, that was really well covered. I think the other thing is that, a standard part of drug development is there are always animal studies that look at growth, that look at reproductive toxicity and development into several generations of animals. And again, there's been no sign of any issues seen with any of the vaccines.
Okay, great. So we're talking a lot about sort of maybe side effects and adverse effects. So there are questions about the association of myocarditis in some teens and the COVID vaccine.
Yeah, so maybe I could start really high level, and I think Dr. Kellner was going to talk about it as well. So there have been media stories and some communications about reports of myocarditis predominantly coming out of Israel, which is kind of ahead of the rest of the world with respect to giving second doses of the Pfizer vaccine. So what they've reported so far is about 275 events of myocarditis out of 5 million people vaccinated, fully vaccinated with the 2 doses. With a suggestion that they were seeing these cases probably more than you would expect in young men between the ages of 16 and 30. So this is really interesting. And again, like anything that could be a serious event associated with a vaccine, there's a lot of scrutiny by all of the regulators worldwide on what these events are and what they could mean. So there's been a lot of information sharing and talking about what we've seen. None of the other countries which are well advanced in second doses have actually seen an increased incidence of myocarditis. So the US and the UK, they've both given a lot of second doses of the mRNA vaccines, and they're not currently thinking that they're seeing an increased incidence. In Canada, we've given over 22 million doses of the vaccines, not very many second doses, and we've seen 25 reports of myocarditis, kind of in more women than men, and with a broad age range. So I think at this point, what we can say is that it's interesting. There may be something there. It's being very, very closely monitored. But nobody's taken any action to restrict the use of the vaccine in any age group. Nobody's making recommendations that people should not get a second dose, but it's something that's being followed very closely. What the cases that have been reported have been very mild for the most part too. So I'll stop there and I'll let Dr. Kellner talk about it as well.
Yeah, and I don't have too much more to offer, but just to pick up on the last point that is that the cases that have been reported have generally been very mild. So myocarditis, what is that? It is an inflammation of the heart muscle, and people may have heard of pericarditis as well, which is a related disorder where there's inflammation of the lining of the heart, and you can get one or both that can occur. And these are rare conditions in general, and the vast majority of cases of myocarditis are thought to be related to being triggered by a viral infection. We see it in newborns sometimes related to a maternal infection or early newborn infection. And then as well, you see it in adolescents. And for reasons that aren't clear, it definitely tends to be something even in regular times that's more predominant in males, not just a little bit, but like 2/3 of cases in males, and not clear why that is. I mean, being male is more deadly than being female for any health issue. So the key question of whether these cases that have been reported have occurred at any increased incidence, comes back to the safety monitoring, both in the clinical trials and in the large scale safety efforts and AFI reporting, and then things like the Canada's COVID study, where anything can get reported. And the question is, does it exceed what you'd expect as a background rate? And that, and again, especially from what we know in the UK and US, not evidence yet that it exceeds the background rate. There was on Friday just a report of 7 cases from the US in young males from 15 to 19 that was reported with some clinical details, and it's sort of striking for all of them how mild these were. Some, it can be a severe thing to have happen, but these were very mild, resulted in short hospitalizations, some treatment, but they typically occurred within a short single-digit number of days, 4 or 5 days after getting vaccinated, that they became apparent. They were febrile illnesses most often, and while workup was done to make sure that they didn't have COVID and they didn't have MIS-C, you don't know that it couldn't have been another cause for it. And I'm not saying this in a defensive way to say, well, maybe it was something else. It's just, it's as is usual, though we know and anticipate that myocarditis is generally caused by a virus. This is one of those situations where it's hard to find evidence of the virus at the time, because very often it's a post-viral kind of thing that can happen where it comes up sometime afterwards. So while we expect that it's caused by viruses, we don't prove it very often. So the lack of evidence of another virus doesn't prove that it was the vaccine. It's a really important thing to keep on keep on top of, and everybody everywhere is watching this closely.
Great. I think maybe we're going to switch gears a little bit and talk about the vaccine rollout. So Rachel Martins, I'm going to ask you to unmute yourself.
Hi, I have a question today talking about mobile options, as well as just basically rollout for children who have a variety of disabilities, behavioral issues, things like that, such as autism. One of the challenges that I have seen in my own work, partnering in a variety of COVID-related outcome research, has been essentially great intentions at a federal level for rollout for disability-related policies, but they kind of start to level out in not the greatest fashion at a provincial level. So why have things like mobile options become more minimal an option, and how do we start to campaign for accessible, safer options for vulnerable children as we continue to move forward?
Okay, I'll start to offer on this. So what you bring up, thank you very much for your question, Rachel. What you bring up is the critically important issues about rollout for particular populations, as well as differences from province to territory. And one of the challenges with this whole pandemic has been that we've seen highlighted once again that the way that our health system is organized across the country isn't always most efficient. So we have federal health principles and federal health regulation, but then we have provincial and territorial health rollout and operationalization and funding, and although there's federal funding as well. And it ain't perfect, but I'm not a politician. I don't want to digress into that, but you know, it could be better. And some things have gone really well, others less so well. But I think one thing you're getting at is this thing of how to reach populations. And for sure, I think one thing that has been, to me, reassuring a little bit is to see that there have been these efforts, but everyone takes effort to try to say, how can we do better with rollout of vaccines? You know, at the beginning of it, when there wasn't very much vaccine around, and at the beginning of it, when it was mostly Pfizer and Moderna, and then Pfizer especially was so restricted in terms of how you could give it in because of the freezer requirements, which have now thankfully been relaxed significantly, which makes all the difference in terms of being able to get the vaccine out elsewhere. But it had to be pretty centralized at first because the vaccine that we were dealing with had to be centralized, and you had this, and so people had to come to the vaccine, and so that's not a perfect situation. And things have evolved a lot since then, and there's a lot more flexibility. There's still time limitation on how long vaccines, and especially mRNA vaccines, can be in fridges, but they're much more flexible now, which is good. And the other thing that's come forward in this has been this recognition that, okay, not all populations have equal access to vaccines, even if you have more readily available clinics and facilities to be able to provide vaccines throughout communities. And this has been with children, as the example you mentioned of children who can't make it in. And so how do we do portable clinics? And then other populations where we just have to do a better job of going to those populations. And I think many of the centers across Canada have done a good job in recent weeks with trying to have vaccine delivery in sites that are more closer to home for people who have more difficult getting access to vaccines. Still doesn't answer your question of getting to home. And I just think it's a thing where that's another wrinkle on how do we properly deliver vaccines through a system of providing care in the home for people who can't make it out of their home. I think we're getting there with some examples of this, and it's been really aided and abetted by the vaccine being having less stringent and freezer requirements. So I haven't answered your question to say how it's happening perfectly. I'm not aware of a place in Canada, and perhaps somebody else is, where it's happening really well so far. But I think as the vaccine delivery supplies have increased, the stringency of freezer requirements has decreased. There's not a reason not to be doing better with that.
Thank you.
Anything to add, Megan?
Not really, because I'm up at the, good intentions at the federal level, but I mean, kind of anecdotally, I am hearing that individual public health units have been taking different approaches, including home vaccinations. So maybe that's one place to start, is with the local public health units. But I think, as Jim said, as the vaccines are more broadly distributed into family physicians' offices and pharmacies, that will hopefully give people some more options, even if they aren't necessarily better for everyone.
Great, thanks so much. Lisa Wolf has a question.
Yes, thank you very much for these insights and the opportunity to ask a question. And I'm not sure, Lisa, to whom to direct the question, but just by way of context, we have the mature minor doctrine that empowers young people to decide for themselves if they will be vaccinated. And in some jurisdictions, existing school policies that would compel it, possibly we'll see the expansion of that. But notwithstanding that, we will still, and I think we're seeing, parent-child differences in vaccine hesitancy or acceptance. So my question is, what are strategies to address those parent-child differences that could get in the way of moving forward in a comfortable way for young people to get vaccinated?
That's an easy question.
Yeah. So I'm not a legal expert, and so, but when it comes to vaccines and adolescents, and again, as with other aspects of vaccine rollout, there are differences across the country. And when it comes to adolescent decision-making, which I'm sure you know Lisa way better than me for everything else, but there's a lot of variety across the country in terms of related to the concept of assent and consent, and where children become involved in the decision to be prime. And you know, you talk about a mature minor or emancipated minor being fully responsible for their health decisions. That's a relatively uncommon situation. It's much more the case where children are still, associated with their homes and but become involved in medical decision making through assent or consent process. And this is meant to be extrapolated to vaccines as well. And again, with the school age vaccines, it does differ from province to province. And I'm not expert to say exactly what does or doesn't is or isn't different. I can speak in Western Canada, say that when it comes to COVID in British Columbia, they've put forward to have an adolescent consent that can be used. In Alberta, my province, we started using the COVID-19 vaccine just a little bit based on the National Advisory Committee Immunization recommendations permissive of this just before it was officially approved. And at that time, we built in a consent form process to make sure that parents were aware of the sort of risks and limitations of what we knew at the time. But it was an important thing for some families. That's remained a thing to say that the expectation is that parents are providing consent, except when the immunizer determines that the child can make their own decision. There's the recommendation that parents should attend vaccine appointments with their children, and if not, provide approval through their children or through a written means. It's not a perfect situation, but I guess I just want to say that to try to finalize this, to say that as with other health conditions where we expect adolescents to become involved in the decision making, it's the same goes with vaccine and COVID because of the heightened awareness that people have of it. It's a thing where, how do we overcome and I'd be interested in your perspective on whether, if there's a discrepancy, is it your perspective that the discrepancy is parent wants it, child doesn't, or is it the other way around? My own feeling, not knowledge, is that if there's a discrepancy, I've seen more where it's child wants it, parent not so sure. And that's the thing where then we have to try to support, either way, you have to try to support the family with information to work through it and accessibility to work through it.
Thank you. Yeah, I mean, the data I've seen, including polling we've done of youth at UNICEF Canada, suggests, and it's not directly comparable with the parent reported polling, but suggests that it is, as you say, Dr. Kellner, more likely that young people would be more willing to get vaccinated than their parents might. But we know anecdotally of cases where the opposite is true. So, and yeah, regardless of law and policy, I'm wondering where efforts could be best directed. Is it at making parents more comfortable, perhaps with the kind of thing you're doing today? It's yes, but I guess there's multiple strategies that we're going to need to employ, and don't want to see conflict between kids and their parents at this time, as if we can avoid it.
And just to interject, and I know this isn't part of the question, but one of the things that I see as our key challenge in the coming weeks in Canada, if you look and compare Canada to the rest of the world in terms of vaccine uptake, the trajectory, our line is still very steep upwards, which is, in my view, inspiring and very hopeful. Of course, most Canadians have only had one dose so far, for sure, I get that, but we're starting to focus on getting second doses as well. But most other countries have topped out or leveled off at around 60% of the population. Israel, the UK, the US, closer to 50. And, we're sort of still going steeply up with this. And so I think your point brings forward at least the issue of, if we're going to get a high percentage of the overall population vaccinated, that'll have to include children, and we're going to have to not level off at 60%. So far, perhaps a ever so slight bending of the curve, but still going pretty steeply upwards. And I think, to your point, we need to continue to pay attention to this, have all hands on deck. Everybody's tired of COVID-19 and everybody wants it to go away. I get it, totally get that. But it's not the time to sort of, let off foot and say, oh, well, it's good enough. We've done pretty well. That's good enough. Because I think doing really well with vaccinations against COVID is we're going to have to be at a place where we're at higher than 60%. I don't think 60%, that's my feeling, but it's an educated feeling that 60% is not a perfect place to level off. Might be for the summer, but variants and winter comes back and everything else and lifting off public health restrictions. I don't think 60% is going to cut it. I think we have to get a significantly higher number of the population immunized, but I'm editorializing now, so I'll stop.
Okay, we're just about at the end of our hour. I'm just going to try to squeeze in one more question, and I'll ask Sarah Schultz.
Hi, thanks so much for taking time to answer all of our questions today. It's super helpful. I'm based in Ottawa, Ontario. I'm a mom of 3. They're 8 and 6 and 4. So my question is about children under 12. And I'm wondering if you can share any updates on the trials and recommendations for children under 12. Moderna is doing some. And as you crystal ball it, what kind of timing might we be looking at for that age group? And as a follow-up, how is public health balancing any of the risks or side effects that could be unique to that age group? Thinking too of the 0 to 2 age of the vaccine with the risks of COVID for that age group in particular. Thanks so much.
So I can probably start. So all of the manufacturers are planning or are already doing clinical trials in younger kids. So both Pfizer and Moderna have ongoing trials for kids aged 5 to 12, and then they're also planning to go to that much younger age groups, including down to about 6 months. I would expect these trials to take longer. I think there'll probably be even longer follow-up. At this time, I can't predict when the results would be available, but I would think after the end of the summer at this point. So it'll be a little bit longer before we have any data on those much younger kids. And I think like everything else, it's kind of, we'll look at the data, determine is it safe, is it effective, and then decisions can be made about rollout and how it all fits into the context of everything else that's going on in the public health system.
Wow. Great way to finish our hour. Thank you, Dr. Bell and Dr. Kellner, for joining us and answering all these questions. I'm sorry that we didn't get to all of the questions, but I think we covered a really broad range of topics and themes. And I will be sharing some of the Health Canada resources post this session, and hopefully we can, as we learn more, hopefully we can come back together again and answer some other questions as our body of knowledge grows. So thank you everybody for coming today, and thank you Megan and Jim for all of your time. Have a good afternoon, everybody.